Okay, welcome back. So, it has been a day yesterday which everyone saw on the news channels that it was another day and the Delhi pollution that we had. Okay, so maybe the politician thought one day that let's not argue with life and move on like Bhupendra Jogi did. Yes, because in Delhi where I stay basically, we all think that we are not a smoker, but we are a smoker. As I rightly say, kids smoke cigarettes, Mansoor Cigar, and legends live in Delhi NCR. Okay, let's start with the discussion that we have with us in the workbook for the neurology chapter. Okay, let's start with the very first topic that we have in the workbook, that is seizure disorder. Seizure disorder, which is focal, if you know, seems to have a focal behavior every time. And this focal behavior in the patient could be motor or can be sensory, depending in the area in the brain being involved in the patient. And please remember, the onset in this patient is always found to be discrete. A discrete lesion, which can be a space occupying lesion that we already know, which can be a tumor, abscess, or a cyst. The third point that we have always in favor of a focal seizure is that they usually have got a post-ictal confusion with them. And they generally have got aura also. They know that it's all coming to them. Aura is seen generally in a patient of focal seizure. And these patients may lose the consciousness during the episode of focal seizure or may not lose it at all. So there are two kinds of patients that we have. A focal seizure that we have with us with LOC is known as focal seizure with the impaired awareness, and focal seizure with the intact awareness. Right? And out of all the drugs that we generally have with us in treating a patient of focal seizure, the most preferred most of the time, the topmost, has to be lamotrigine nowadays. Okay, so that's a quick recap of focal seizure disorder that we have with us. So what did we learn? It has got a focal behavior which can be motor as well as sensory. The onset of it is discrete due to a space occupying lesion. There is an aura, there is a post-ictal confusion. With LOC is impaired awareness, without LOC is intact awareness, and the most preferred drug in them is a lamotrigine. Then we have the ABCDE, the absence seizure. If you remember about the absence seizure, the age of onset is 4 to 8 years generally. So there are a lot of specification regarding the most preferred drug and the drug of choice in these patients that we have already done in the class. This is just a quick revision of what we have with us the previous notes. Okay, and the classical presentation of absence seizure is coming to me with a behavioral arrest. And during the episode of the behavioral arrest, these patients give me a typical stare look. Okay, there is obviously a post-ictal confusion that is seen in them. And don't forget, the drug of choice that we often consider for absence seizure is what? Ethosuximide. Right? And the EEG. Please stop spamming in the chat box, otherwise we'll just throw you out of the eMedicos app. Okay? Stop spamming, please. And the EEG that we have in patients of absence seizure shows to me a 2 to 4 hertz typical pattern that we have with us, a spike and a wave. A spike and a wave pattern that could be seen in the patient on the EEG. And we all know it is all precipitated by hyperventilation. So look at this patient. He gives you a sudden onset stare look or a blank look that would be seen in patients of absence seizure. Yeah, a quick correction. In absence seizure, there is no post-ictal confusion. A quick correction. In absence seizure, there is no post-ictal confusion. Okay. Then we have GTCS with us, a generalized tonic-clonic seizure. In these patients, generally we have a generalized onset. Generally, this generalized onset happens in them due to a kind of lesion that we know as a diffuse lesion. Apart from this, if I look at the patient of GTCS, they do come to me in a tonic phase and then followed by a tonic phase. The tonic phase, the patient will show a lot of stiffness in the body, especially there will be flexion in the upper limb, and then obviously there will be an extension that will be seen in the lower limb. A kind of posturing pattern that we often resemble and known as the decorticate posturing. Decorticate posturing. Then we have the next phase, the clonic phase, in which the person keeps on continuously moving or jerking. In the tonic phase, we usually have got a sound or a loud cry of the patient known as a ictal cry, and of course with some cyanosis that could be seen in them. In the clonic phase, obviously, we have with us in our patient a frothing. And then there is a sleepy phase, that's the post-ictal phase. After the seizure, the patient lies flaccid, and obviously they come to me with urinary incontinence. Okay. Then we have the juvenile myoclonic epilepsy or the JME. In JME, we usually have with our patient a juvenile onset. The onset of this early happens in the early adolescence. In these patients, the many seizure types are generally seen, and the most common seizure type seen in them is always a jerky movement that is known as myoclonus. Majority of these patients, if left untreated, would develop an episode of GTCS as well, and 1/3 of these patients could even have an absent seizure. So many seizure types are seen in a patient who is having a juvenile onset of seizure disorder, that's juvenile myoclonic epilepsy or the JME. So as you can see over here, this is a typical myoclonic jerk that is seen over here. EEG that we show in them or that we find in them, or many spikes could be seen in them, polyspike pattern could be seen on the EEG. I know, there are a lot of points in every topic that is for the classroom teaching. This is a quick revision program, so I'm only highlighting you the important points that you remember for the exam, right? Let's try to get wiser on this topic by solving an MCQ. Following statements are true about epilepsy except Jacksonian epilepsy is a spreading seizure activity. Yes, if you remember Jacksonian March, Jacksonian epilepsy, the seizure would start in a limb, generally distal, and then would go into the limb proximal. Serum prolactin increases dramatically after a tonic-clonic seizure activity. Yes, it generally happens to increase after a tonic seizure activity or a true seizure disorder. Option D, absent seizure are briefer and more frequent without post-ictal confusion. So the correction that I made earlier, there is no post-ictal confusion seen in them. It's a brief stare look that the patient will be having, and it is often precipitated by hyperventilation. That's an important point now. So the patient is hyperventilating most of the time in an age group of 4 to 8 years, the onset part. So the episodes are very, very frequent for them. And look at option C. Changes in memory and perception and blackouts are not feature of focus seizure with impaired awareness. That's wrong. So if the focus seizure with impaired awareness comes to me, they will always have a problem in perception. They will give me a blank look or a stare look, and they will not remember what happened during the episode. They generally suffer with a kind of an amnesia that we refer as anterograde amnesia. Option B reads serum level of prolactin increases dramatically after tonic-clonic convulsion. That is defining a true seizure. After a true seizure, not pseudo seizure, the prolactin would be generally high in them. So that's a correct statement. We are asking you about except what is false or incorrect in this. That's option C. Let's move ahead into a topic that always improves our status in the exam, the status epilepticus. To define status epilepticus, remember the seizure that we have in the patient would be there for a duration most of the time more than equal to 5 minutes. So the duration of seizure that we count in them is found to be more than equal to 5 minutes. Generally a trigger is seen in them for a status epilepticus, that is abrupt cessation of anti-epileptic drug. Apart from this, other factors like electrolyte imbalance, head injury, of course, can be an important risk factor for trigger. In them, the altered consciousness could also be there. That means these patients will suffer with the loss of consciousness, the LOC, that would last in them for a duration of more than equal to half an hour. So now we have two kinds of status epilepticus with us. Is this convulsive and non-convulsive. So the convulsive status epilepticus in our patient that we have would have a seizure for a duration of more than equal to 5 minutes. A non-convulsive, yes, would also always have an LOC for more than equal to half an hour. The word non-convulsive comes with the reason they don't happen to see a seizure proper. Okay, they're just lying unconscious, interictal, postictal for more than half an hour. Treatment of choice is always a sedative that we keep in mind, that is lorazepam or shorter acting benzodiazepine analog. Now the use of anti-epileptic drug to be taken care of status epilepticus depends on the patient. If the patient has stopped the drug and has gone into status, we need to restart the old anti-epileptic drug. If in the patient they've got head injury as a protocol goes, then in that case levetiracetam is considered to be a healthy anti-epileptic to start with. Sedation in the sense general anesthetics like propofol and thiopentone or midazolam can be given only in cases of refractory status epilepticus. So the word refractory means who was not responding to the standard lorazepam therapy and the standard anti-epileptic drug therapy. In them you need to give sedation. So there are two kinds of refractory status epilepticus. One is early and the other one is late. The early one is the one in which the seizure is lasting for a duration of more than half an hour. And the late refractory is the one in whom the seizure is lasting for more than equal to 2 days or 48 hours. So depending on the situation, again, we choose the best and a sedative drug to be given. For an early refractory status epilepticus, please remember, the ideal drug of choice that we keep in mind is midazolam infusion. And for the late refractory status, it's always thiopentone. Okay. So this is something that we all should know about the status epilepticus, a topic that will always improve your status in the exam. Okay. Then we have with us pregnancy. Another factor that we need to keep in mind while treating a patient of status or any other epileptic patient if they are pregnant. Please repeat, we lost connection. Sedation part. Forgot. Sedation is something that we'll give to our patient in status epilepticus in two formats, early or late. Early or late, what we know as refractory status epilepticus, who is not responding to the standard therapy. Early is defined as a seizure which is lasting for more than half an hour in duration, and late wala is defined as a seizure which is lasting for more than 48 hours in duration. Okay. And early refractory status epilepticus, you give to a patient midazolam infusion. Late refractory, we give to our patient thiopentone. Okay. Then we have pregnancy as another important factor. If the female is epileptic and pregnant, the safe anti-epileptic drugs that we have with us in the group is LOL. LOL. L stands for the lamotrigine. O stands for the oxcarbazepine. And the last L stands for the levetiracetam. Already on anti-epileptic drug, please remember, please continue the drug along with the folic acid supplement. That is important to prevent in a pregnant female what? A neural tube defect that could happen. Evaluate what in pregnancy? Two things. Evaluate the fetus for any congenital malformation if they are developing. Secondly, evaluate the anti-epileptic drug with the serum levels. Serum levels. Okay. Right. So that's a quick recap of a female pregnant and epileptic both. 29-year-old 4-month pregnant, primea gravida, first time pregnant with history of juvenile myoclonic epilepsy. Someone was asking this also, what is the drug of choice for JME? It's valproic acid or valproate. She is regularly taking valproate and now seeks an opinion for an anti-epileptic drug regimen. What should you suggest her? Continue valproate with monitoring of the drug level. Simple? Correct? Do not change the drug. Changing the drug will precipitate seizure. Continue the same drug with monitoring of the drug levels. To know the drug is in the therapeutic range, not in the toxic range. As the moral of the story is always like this, you have to maintain the patient on monotherapy and at the lowest effective drug dosage. Okay. Now let's move into another topic in which the patient is slow, but we are very fast and quick learners to learn it. That's Parkinson. So this patient is very smart and we have to be smart for it. These patients of Parkinson, if you see them standing, they always have got a bent over posture that we know as a stoop posture. They always have got a festinating or a shuffling gait while walking. While they walk, they have always got a stoop flex posture. And when they start walking, they take shorter steps and start running as if they are ready to run somewhere. When you see their legs, they will be moving very fast like you are shuffling your cards while playing them. So that's a shuffling or the festinating gait that you see in patients of Parkinson. Mask-like face that we have in them, a typical face which is seen to be expressionless. Akinesia, yes, they will always have it, slowed down movement with the rigidity that we know as cogwheel, and the tremors that they show is typically known as a resting tremor. Okay, so this is a patient of Parkinson that is having a stoop flex posture. This is a rigidity in a pattern that is the wheel in a machine that is trying to move with some cogs all over, the cogwheel rigidity. If you look at their hands, they're having tremors which are resting. They're not covering too much of distance in a single step and they're trying to run while walking, the fascinating gait. And if you pull them back, they will come and fall over you. Yes, they've got another problem with them known as postural instability. Right? So there are some doubts that are still lagging behind in epilepsy and pregnancy. If she's in the first week of pregnancy and she's on valproate. See, the point is this, that valproic acid causes neural tube defect, but it's not 100%. The chances of having an NTD in a valproic acid therapy is 10 to 20%. Versus not on valproate is 1 to 2%. So the ideal therapy is to start folic acid in such patients preconceptional as soon as possible when they visit you before pregnancy. And if she's on valproate and she conceives, don't try to change the drug as per the recent guidelines. Maintain her on valproic acid at the lowest effective dose. And if you are giving folic acid in the first trimester also, it will be quite helpful for the patient. Okay. Mask-like face is an expressionless face. Treatment. So the treatment of Parkinson is very simple. It's a cold salad that the patient is going to have. So one kind of treatment that we have is a COMT inhibitor, or maybe the drug of choice for treating a patient of Parkinson is always a precursor of dopamine, that is levodopa. Anticholinergics are also important in treating patients of Parkinson. For treating what? Tremors. Apart from this, the dopamine agonists are also very helpful in these patients. The dopamine agonist that we have with us could be divided into a type oral. It can be seen in form of a patch and injectable, right? The oral one that we have with us is roperidol. The patch that we have with us is rotigotine, and the injectable that we have with us is apomorphine. But we need to add certain drugs to the patient to have an improved dopamine level, especially after giving levodopa. Like we have these UMT inhibitors with us, two brothers, the entacapone and the tolcapone, and silyzalin, which is also known as the MAO-B inhibitor. Amantadine is another drug that we give to the patient, and it helps to improve the central dopamine level in the patient. But remember, for the exam purpose, drug of choice is levodopa, but it's not only levodopa every time. You have to give it with what? Carbidopa. So it has to be a levodopa and a carbidopa combination that we generally give to the patient. Now that's a very simple question. If you can answer me, which of the following is most useful in the diagnosis of Parkinson? Therapeutic response to the drug, history, clinical examination, EEG, or the CT? Obviously it has to be clinical examination. That will be always most helpful thing to diagnose a patient of Parkinson. Okay. Then we have atypical Parkinson, one of the favorite topic of all the examiner recently. In the atypical Parkinson that we have with us, progressive supranuclear palsy, or the PSP, in which the patient's posture seems to be always extended. They've got stiffness in the body, especially if you can see on the axial region and the neck region, which keeps them always standing in an extended posture. And poor gaze. The poor gaze is in the downward direction. So they have got a poor downward gaze every time. So when they walk with an extended posture and they cannot look down easily. So they end up having a frequent fall also with them. Patients of Steele-Richardson syndrome, also known as the progressive supranuclear palsy. Multiple system atrophy. These autonomic symptoms are seen perfectly in them. There are obvious cerebellar signs that could be seen. In the patient of multiple system atrophy, if they have autonomic system symptoms, they are known as MSA-A. If they have cerebellar symptoms, they are known as MSA-C. MSA-A is also known by another term known as Shy-Drager syndrome. In these patients, we have symptoms of Parkinson along with cerebellar symptoms and autonomic problems. Sometimes we might give them a trial of levodopa, but they usually don't actually produce good relief of symptoms if you give them a trial of levodopa. So trial levodopa, poor response. That is a patient of multiple system atrophy. Okay, known by a simple atrophy mnemonic. Then we have dementia of Lewy body with us. Lewy is slow, Lewy is sleepy, and Lewy has got what? Hallucinations. Lewy is slow, Lewy is sleepy, Lewy has got hallucinations. So Lewy is slow for the reason he is suffering with symptoms of Parkinson. Lewy is sleepy, in a sense he's got dementia, and Lewy has got hallucinations. Hallucinations that are usually seen in them as visual hallucinations. So Lewy is slow, Lewy is sleepy, and Lewy is L-E-W-Y, Lewy, hallucinations. Okay, a simple mnemonic for this. Then we have the corticobasilar degeneration, in which the patient comes to me with slowness, obviously due to symptoms of Parkinson, with atrophy that is seen in these patients in the midbrain region causing Parkinson, and it can also be seen in them with a parietal atrophy. So the lesion that could be seen in them is in the midbrain and the parietal region, and whenever you have parietal region you end up having apraxia. In these patients there is another behavioral abnormality that could be seen, in which their hand is not under their control, alien limb phenomenon. Many of the students who have attended lectures already with us know this phenomena, in which the hand doesn't work on its own, it works under control of someone else. That's the alien. Like right now, you're studying, you're reading with a textbook in your hand, but some people have got habit to catch their mobile phone and type something. Karte raho, karte raho, karte raho. Arey yaar, this is not the exam that is going on over here. Okay, this is not the fastest fingers first that I am playing for KVC. So control your hand. Okay. Oh, MCQ. 68-year-old man with a 2-year-old history of dementia frequently developed daytime visual hallucination. So memory loss with visual hallucination and bradykinesia. All together defines what? Dementia of Lewy body. Right? So now let's try to see the movement disorders in a different way. The speed of movement, is it slow or is it fast? The range of movement, is it none or is it large? So a simple thing that we can help you out in understanding this, the biggest circle. The range of movement is not that good, and the movement also is very, very slow. Look at me, diagnose this for me. My hand is like this all the time. Now to pick up my mobile phone, my hand goes very, very slow there. What is this? Can someone of you identify this problem for me? My range of movement is very, very poor, and the speed of movement is also very, very slow. Now don't tell me Parkinson, please. It's bradykinesia, I know that. No. The range of movement is not too far away, and my hand is always there in a sustained posturing like this. My hand is in a sustained posture like this. Sang mala jo mala maite nahi. Tell me something which I don't know. Still waiting for the answer. The moment you hear the word slow, you think of ethitosis. No, galat jawab. Sang mala jo mala maite nahi. Arey babre. Spasticity. Quite near to spasticity. That's a quick hint. Quite near to spasticity, in which the limb attains a sustained posturing due to increase of muscle tone. And the range of movement is very poor. Don't tell me paralysis. Kaun hai mar? Yeah. Now you hit the bullseye. That's dystonia. Correct? Simple? Right. Now we have a movement which is slightly faster than dystonia. I'm not calling it as rapid, but slightly faster than dystonia. But the range of motion here, yes, the range of motion is still very poor. The range of motion is still very poor, but it is faster than dystonia. Now this is what you are telling me about. Yes, the pushpa, right? A, ethitosis. Now we have another movement disorder on this side, the small circle, in which the range of movement is very large and the movement is very rapid. What is this? Yes, that's the bhangra that I was trying to do. Yes. Bhangra B. अरे कोरिया नहीं था यार. We do bhangra on proximal joints and move a hand like this. That's B, the bellismus on one side, hemibellismus. Now the range of motion is not that large as bellismus, but the movement is still very rapid. Yeah, this you are thinking about what? The chorea. So that's a quick summary of the movement disorders that we have got with us. Okay, now let's try to answer this question. Chorea is defined as slow breathing movement. The word breathing means slow sinus movement, very slow, that's ethitosis. Sign of restlessness. What is this restlessness? I saw a patient in OPD of psychiatry. He was very restless while sitting. He was moving every time like this. Very restless. What is that known as? So I have a patient in psychiatry OPD sitting outside who's an antipsychotic, obviously, not for psychotherapy. And he's very restless. Keeps on moving here and there. That's known as akathisia. If option A, very good. Akathisia. So I just forgot the spelling. That's a ninja technique to remember the spelling. Ask you, you'll tell me the right spelling. I hope still I'm not correct in that. Akathisia. Slow and rhythm movement. Athetosis. Now we have a shock, irregular movement, shock like movement. The person is sitting, he's doing like this. I touch him, he does like this. What is this known as? Shock like. That's myoclonus. So we are left with only one answer by exclusion, brief and twitchy movement. So chorea is a brief semi-purposeful twitchy movement. My hand goes and goes out like this, a very twitchy movement. Okay, right. Right, so that's a quick recap of the movement disorders in a simple diagram. Now let's have a recap on the tremors. We have tremors in which the hand keeps on rolling like this. This is the resting tremor. Resting tremor we already seen in patients of Parkinson disease. Then we have the action tremor. My hand is away from my nose, and when it touches the nose, the tremor happens to be seen there. Yes, that's known as the intentional tremor. And then finally we have a tremor in which the hand like this outstretched to maintain the posture is there. So tell me this tremor, which is fairly common in the family history, in which the hand is outstretched like this to hold the posture, the hand keeps on shaking. Now don't tell me it's resting. No. It's not fine. You can see it from a distance. Like the mobile phone starts ringing, Sometimes my hand starts shaking from distance also. No, that's not flapping. That's not flapping. That's not flapping. Flapping is like this. It's not the aeroplane wings which are flapping. Arey babre, essential tremors. Essential tremor is often known as postural tremor. To hold or maintain the posture, it happens there. Now let's answer this question. 21-year-old pianist noticed a fine tremor in both hands that was little more prominent while playing a piano. Her physician told him that it was a physiological tremor. What should be the ideal treatment for it? Should I start the patient on sodium valproate, neuroleptics, levodopa, or some kind of a beta blocker? Tell me. Can you diagnose this? What is this? What are we talking in a way physiological tremor that happens when playing a piano in anxiety? Again, the essential tremor. And for treating essential tremor, the ideal treatment is what? Propranolol or the beta blocker. Correct. Right answer. Now let's move on to the stroke, the ACA infarction, the first one. In a patient of ACA infarction, usually we have got an apraxia of walking known as gait apraxia. Since the patient's lower limb is only weak, he cannot walk easily. So he keeps on dragging his feet on the floor. The realistic Shivali gait, yes. So that's a gait apraxia patient. They've got the control over the lower limb and the bladder. For the very simple reason, the paracentral lobule, the medianmost part of the brain, is supplied by the anterior cerebral artery. Any lesion over there will cause motor weakness in the lower limb with, of course, urinary incontinence. Abulia. Abulia means doesn't want to do anything, lack of motivation. So their patients often have got lack of motivation to do anything good in life. They are ebulic people. So these are the three classical symptoms that we'll find always in an ACA infarction. Which of the following is not seen in an ACA infarction? Tell me. Urinary incontinence will be seen. Antisocial behavior is also seen because the prefrontal lobe 9, 10, 11 area is supplied by the ACA. Transcortical motor aphasia, that will read in aphasia later on, yes, is also seen over here. But one thing is not seen, hemiparesis. A patient with an ACA infarction will only have the lower limb weak, not the upper limb weak. And hemiparesis means upper limb and lower limb weakness both. Okay. MCA infarction. Let's change this, the MCA infarction. These patients have got weakness in the body with sensory loss, also known as hemiparesis and hemianesthesia. They often got homonymous heminopia due to the involvement of the optic radiation. They got aphasia, yes. If the lesion is on the left side, the left MCA, then they will have aphasia also as a problem. They got neglect, hemispatial neglect. This happens in them due to involvement of the right side, the angular gyrus. Correct? So if you remember the hemispatial neglect topic, never forget this. So the patient will make a clock with a round circle with numbers projecting only on one side, not on the left, always on the right side. And the Gershman syndrome, which includes dyslexia as a complaint, will happen due to a lesion in the left angular gyrus. An eye deviation in ipsilateral gaze preference. So wherever side the lesion is there, the eyeballs are going to move over there. So that's an important topic, the MC infarction. Just have to know the difference between the left and the right. Aphasia will happen when the lesion is on the left with the Gershman syndrome with an ipsilateral gaze preference and contralateral hemiparesis and hemianesthesia. Okay. Now the PC infarction, the pain is lost in them due to the involvement of the thalamus. These patients have also got the cortical blindness due to the involvement of the occipital lobe. These patients have got amnesia as well due to the involvement of hippocampus, and pure word blindness or alexia is seen in them. Yes, due to the involvement of the splenium part of the corpus callosum. Corpus callosum. Now let's try to answer this question. Which of the following is not seen in a PCA infarct? Cortical blindness is seen in them. Yes. Alexia is seen in them. Amnesia is found in them. But there is no weakness or hemiparesis. So weakness in the lower limb is ACA infarct. Upper limb, lower limb is MCA. And PCA doesn't typically present with hemiparesis as a presentation. Okay. Let's try to remember this topic by this diagram. A simple line diagram. If you follow this, these eyes of the patient look like P. Yeah. So this part includes the PCA infarction. So what is there specific in the PCA infarction in these patients? They will have a cortical blindness. They will always have a cortical blindness. Can you tell me what kind of blindness is this? Cortical blindness is sparing of the central part. Yes, the macular sparing. Now look at the M. The MCA infarction causes problem in the mouth, that is in speech, aphasia, right? And weakness that would be seen in the patients, upper limb also. It also looks like an M, right? And look at the A below. If you look at the A below, that looks like ACA. In the ACA infarction, the patient's lower limb is weak. It's something over here, bladder, the urinary incontinence. So urinary incontinence with lower limb weakness is a feature of ACA infarct. Upper limb, lower limb weakness with aphasia is a feature of MCA infarct. Cortical blindness with macular sparing, as you told me, is a feature of PCA infarct. Apart from this, they will have pure word blindness, alexia, amnesia also in the patient. Right? Chalo, which aphasia will be seen in a complete left MCA infarction? Tell me. Now the MCA, if you remember, has been divided into two parts. The proximal and the distal part. The proximal part is the M1 part and the distal part that we know is the M2 part. That would be seen over here. Right? So complete left MCA infarction means the complete MCA is involved over here. So Broca's and Wernicke's both are gone. We'll have what? Total aphasia gone, known as global aphasia. Not Broca's aphasia, not Wernicke's. It will be global. Look at the complete word. Complete means both superior and inferior division are lost. that can only happen when the proximal or the M1 part of the MCA is involved in the patient. So the superior division, inferior division involvement could also be known as partial occlusion, not a complete occlusion. Okay. So let's quickly revise aphasia also in a simple way. So that's a crisscross table that I've given over here for a quick revision of aphasia. Now please be with me on this topic. Right. So I have a patient with me. Look at the scenario. I have a patient with me whose reputation is lost, whose naming is not mentioned over here. His comprehension and fluency is intact. So can you define me an aphasia? Tell me this one first. Whose comprehension is present, intact, whose fluency is intact, his reputation is lost. Okay, I'll give you another hint over this. His naming is also lost. So there is an aphasia with us whose fluency and comprehension is intact, while the two in between variables, the naming and reputation, is lost. Please tell me. Good. So this topic has conducted into your mind centrally. So what is known as conduction aphasia. Very good. Happy. Mogambo, बहुत खुश हुआ. Now let's try to follow this. There is a patient with me whose reputation is lost, whose comprehension is lost, but his fluency is intact. Okay? A patient with me whose reputation is lost, whose comprehension is lost, but his fluency is intact. He can speak but doesn't understand. I have a patient with me, I repeat, whose reputation is lost, whose comprehension is lost, but his fluency is intact. Very good. One case aphasia. Excellent. Okay. Now I have a patient with me, the next one, whose fluency is lost, right? His reputation is lost. Whose fluency is lost, his reputation is lost. His comprehension is intact. Tell me now. His reputation is lost, his fluency is lost, but his comprehension is intact. Very good. Broca's aphasia. So go with this table on this side, maybe on the other side, which I am trying to project, are the people whose fluency and reputation is lost. Now I am going to project you the people whose reputation is intact, right? And let's try to find the other variables. So the downside of this diagram, the reputation is always preserved. So let's try to calculate this now. Tell me a patient whose reputation is preserved, his fluency is lost, his comprehension is intact, but his reputation is preserved. So there has to be a transcortical aphasia. Just a quick hint. Transcortical aphasias are brothers and sisters of Wernicke's and Broca's with preserved or intact reputation. So my patient's, I repeat, reputation is preserved, fluency is lost, and comprehension is intact. Very good. He is a brother of Broca's known as transcortical motor or the interior transcortical. Excellent. Very good. Now let's try to look at this. A patient in whom the reputation is preserved, comprehension is lost. I'll put a question mark on this box now. A patient in whom the reputation is preserved, comprehension is lost, and fluency is preserved. So look at these variables now. The fluency is preserved, the comprehension is lost, and reputation is preserved. Yes, the brother of Wernicke is known as transcortical sensory aphasia. Excellent. Now we are left with the last one. That's very simple. Fluency is lost, Comprehension is lost. Repetition is the only variable which is normal over here. He is living alone. If you're asking what is your name, Bhupendra Jogi. कहाँ रहते हो? भूपेंद्र जोगी. Where have you been? Bhupendra Jogi. So who is this Bhupendra Jogi? Whose reputation is intact, his fluency is lost, comprehension is lost. Identify this Bhupendra Jogi for me. Yes. He is Bhupendra jogging. He's running away from the people, no? So don't take stress in life. Be like Bhupendra Jogi. Keep on moving. Isolation aphasia or the mixed transcortical aphasia. क्या मुश्किल है? It's very simple topic, provided you have your concepts very clear in your mind. And 2 minutes of silence for the people who are listening to this. What is happening over here? ये क्या था? Because if you have attended the lectures on aphasia, you will easily tell me what all are the variables that we are testing and how do you match among them and define what kind of aphasia is it. Okay. So simple, so easy, looking like a wow. 53-year-old woman, sustains a left frontal lobe embolic stroke during cardiac catheterization. She has got a poor naming ability and her speech is decreased, non-fluent. Comprehension and repetition are preserved. Comprehension is intact, repetition is intact, naming and fluency is disturbed. Tell me. Arre. Repetition is preserved. Repetition is preserved. Comprehension is lost. Fluency is intact. अभी तो बोला है सबने. Transcortical. Sorry, fluency is lost. I'm very sorry. Fluency is lost. Transcortical motor aphasia. Okay. Just a quick recap. Transcortical sensory happens due to involvement of the PCA. Transcortical motor, involvement of the ACA, the anterior cerebral artery. Now the AIS, yes, the acute ischemic stroke. What do you give to the patient? Aspirin, antiplatelet. And if the patient has come into desired time window period, you give them a recombinant TPA. You have to give to the patient IV recombinant TPA intravenous if the patient has presented to you within 4.5 hours of the onset. If your patient is having a large vessel occlusion, intraarterial can be given up till 6 hours. But if the deficit is big and the infarct size is still small after thrombolysis, you can give it up till 48 hours. The BP ideally should be on the normal side and the blood glucose should also be normal in the patient. It should not exceed 200 or BP should not be very, very high in ischemic stroke. Okay. So let's try to answer this question, a very simple question. 45-year-old male patient presents with right hemiparesis with global aphasia. Now global aphasia means complete MCA infarction, the M1 occlusion, large vessel occlusion. And the duration of this is 1 hour. The NCCT brain is normal, doesn't show me hemorrhage. The BP is also okay, 160/90. Chalega. Which of the following is the next best step in managing the patient? Should I manage the BP? Or should I go for the MRI to find the infarct size? Or should I do a cerebral angiography to rule out, someone is asking me about LVO, large vessel occlusion? Or should I think about just aspirin? Simple answer, tell me. These are 1 hour away from the onset. I should rule out what? Large vessel occlusion. Since clinically, in the patient he has got hemiparesis with global aphasia. That reflects a large vessel M1 occlusion. Correct? So you have to do a cerebral angiography as soon as possible. See that thing and put the drug there only. Okay? As per this question. But not manage the BP at the moment, because for recombinant TPA therapy, intra-arterial IV, whatever format you want to give, the BP should be how much? Below 185/110. That's enough a reading that we'll keep in mind while thrombolizing the patient. Okay. Hemorrhagic stroke. Let's try to diagnose them. What locations are they in? A. This is a lobar hemorrhage in the cortex. B, C. If I look at B, just over here is a site that I see is putamen, the outer basal ganglia. C. This is somewhere which I see is the thalamus. D is pons, and E is the cerebellum. Out of these strokes that you have, the most common site of the stroke is always putamen. Because the most common cause of hemorrhagic stroke that we find intracerebral is hypertension, and hypertensive bleeds generally happen within the putamen region most often. Okay. Out of all the sites that we have, the operable site in which you can operate and take out the blood internally from the brain is in the cerebellum and the lobar hemorrhage. You operate on cerebellar bleed and you operate only on the lobar hemorrhage. The rest of the patients that you always manage is conservative. Okay. So someone is asking me, sir, the patient has come to you with a global aphasia, why not aspirin? No. You have to thrombolize the patient first to remove the thrombus in the vessel. Okay. Now we have the subarachnoid hemorrhage with us. So we get a CT head done for SAH. That's a quick mnemonic to remember this topic. We do a CT head for SAH. In a patient of subarachnoid hemorrhage, the age of onset generally in them is found to be at or above 40 years. They have got a decreased flexion in the neck region, reflecting in an extended neck or neck rigidity over there. And whenever the SAH happens in them, whenever the hemorrhage happens in them, they always have an exertional onset because the aneurysmal SAH that happen over there is due to some kind of exertional. Okay. They seem to have hurt the neck region. That actually equates to neck rigidity. If your neck is hurt, obviously you'll not move it so comfortably, neck rigidity will be seen. In these patients, we'll always have a thunderclap headache, the worst headache of life. They will generally collapse in a form of loss of consciousness when it happens. Focal deficit, obstructive hydrocephalus, and re-rupture are the three problems which can happen in them later on. They're often referred by another name as the delayed deficit. The focal deficit, in a sense of hemiparesis or any problem, happens in them due to vasospasm. Obstructive hydrocephalus due to impairment in the flow of the CSF could be there, and re-rupture, once it ruptures, it can again rupture again. Please remember, the most common cause of morbidity in a patient of SAH is always vasospasm. The most common cause of mortality in a patient of SAH is always considered to be re-rupture. Surgery is another step for treating aneurysm. If you want to do surgery in a patient of SAH, you can do clipping, you may do coiling. And another problem which is delayed deficit that could be seen in them is hyponatremia, low sodium. Hyponatremia, the patient will have raised ICT, and of course in them will have increased release of BNP that will cause natriuresis and loss of sodium into the urine region. Hyponatremia. Chalo, let's try to answer this question. Try diagnostic for pinpoint pupil pyrexia and paralysis. Tell me. Intentionally, I did not tell you the clinical features. Just a quick recap. If it is a patient with a cerebellar hemorrhage, they will have ataxia. Putamen, they will have hemiparesis. Thalamus, sensory loss. Now the patient has got pinpoint pupil pyrexia and quadriparesis or paralysis. Who is he? a patient of pontine hemorrhage. Which of the following are the common potential complications of subarachnoid hemorrhage? Re-rupture, hydrocephalus, vasospasm, and hyponatremia. So some people want a quick repetition on the management part of ischemic stroke. I'll tell you again. If a patient comes to you with an ischemic stroke, you have to evaluate the time of onset. If the patient has come to you within 4.5 hours, you have to give them intravenous thrombolysis, just ruling out the contraindication. If the patient clinically has got, like in this question, a large vessel occlusion possibly, then in that case the drug IV will not work properly. You have to possibly give it through the intra-arterial route. But the intra-arterial that we can consider for thrombolysis for a large vessel occlusion is up till 6 hours from the onset. And the deficit infarct size mismatch, and again correction, I'm paying more attention to the chat box actually. That's why this happens. I increase the timing, just correct it there. The deficit infarct size mismatch has to be up till 24 hours, not 48 hours of the onset. Okay. So you have thrombolized the patient and the patient doesn't show any improvement. You can take it up till 24 hours. Okay. Aspirin has to be given 24 hours after the thrombolysis has completed, and BP should be managed well and the sugar level should be always normal. Okay. The collapse in SAH means loss of consciousness. Right? You have SAH, you collapse and you fell down. Now, myasthenia gravis. In a patient of myasthenia gravis, muscle weakness that will be often seen to be proximal, near the joint in the patient, in a format of skeletal weakness that they often have got. And in these patients, they got a symptom of easy fatigue. That's why the name given to it is myasthenia. Asthenia means easy fatigue as a classical symptom. Young age of onset would be seen in them, generally in females. The average age of onset that we take in them in females is 20 to 30 years. In males, it can occur slightly later on, in the 5th and the 6th decade. It's a disease which is considered to be autoimmune because of the thymic abnormalities. Thymic abnormality which could include in them hyperplasia, excessive working of the gland, or a tumor known as thymoma. They will generate antibodies against the acetylcholine receptor. 10% patients of myasthenia gravis have got thymoma, and 65% of them have got thymic abnormality. So overall 75% of myasthenic patients have got something wrong in the thymus in them. That's why it is autoimmune. We create antibody against the acetylcholine receptor. In these patients, we generally have got a high titer of acetylcholine receptor antibodies. In these patients on the face, we have got a snarling appearance, in which the person will give you a smile like this, a vertical smile. In these patients, there are no sensory abnormalities clinically that you will find. So if I look at the patient, the oral area will give me a sensory abnormality, but the majority of the part that we see in them involvement is somewhere of the ocular area and the proximal muscle group. In them, the sensory, autonomic, the deep tendon, and the cognition is perfectly normal, right? They're often exacerbated by certain drugs, like the ofloxacin group or the quinones group, even the beta lactam group, and the aminoglycosides. So 3 antibiotic groups that you need to remember, even the beta blockers could exacerbate this trouble. In them, the ideal treatment is anticholinesterase medications. In the anticholinesterase medication that we often advise in them is pyridostigmine. That is an oral anticholinesterase inhibitor, and it is always considered to be drug of choice for these patients. There is also an immunosuppression that will be required in them. Okay. In the immunosuppressive therapy, don't forget The immediate response that could happen in them could happen with IVIG or plasma pheresis. An IVIG therapy is generally given in form of myasthenic crisis, in which the patient develops respiratory muscle weakness and is ready to come on a ventilator any moment. Okay. A quick recap about his cousin brother Lamberton-Eaton myasthenic syndrome. It is a kind of a paraneoplastic problem in which the basic problem is a lung cancer, the small cell carcinoma of the lung, and they develop an antibody against the PQ type of calcium channel, which are presynaptic on the nerve terminal. And these channels are very important in them to improve the acetylcholine release from the nerve tissue. The muscle weakness that we find in them is skeletal more often, then facial, then ocular. In myasthenia, it is ocular, facial, and then skeletal. The rapid nerve stimulation that we do in them will always show me an incremental response. So when I stimulate the nerve, the action potential keeps on improving in them. Okay. Let's try to answer this question. Which of the following about myasthenia gravis is correct? Myasthenia gravis is characterized by presence of ptosis, muscle weakness that improves with increased activity and worsens with rest and fatigue. No. It will never improve on increased activity. It will always actually more weakness will happen on increased activity. It is caused by voltage gated calcium ion channels. Myasthenia gravis, no. Plasma exchange and IVIG are the first line therapy for myasthenia, no. They're only given for patients of crisis. It is essential to check thymus in a patient of myasthenia gravis. That's a correct statement. Because if they have a thymoma, which can have a paraneoplastic or a compressive trouble, so it's always better to remove it as soon as possible. Now going to the brainstem syndromes, another tricky topic to deal with, but I'll make it very, very simple if we go very methodically. So these are the three boxes that we have created. The uppermost box is the midbrain. The midbrain that we have. The midbrain. Then we have with us pons. Just give me a second. Midbrain, pons, and medulla. Right? LEMS is SCC, stands for small cell carcinoma every time. Let's start with the midbrain first. In the midbrain, we have the involvement of the third nerve and the corticospinal tract. That is number 1 by the listing, the Weber syndrome. If you have the involvement of the red nucleus with the third nerve, the next one in the line is a Claude syndrome. If you have 1 and 2 together, that is number 3, the Benedict syndrome. And if you have the involvement of the third nerve and the superior cerebellar peduncle, yes, that's number 4, North-Nagel syndrome. Okay, simple. Then we have the Pontine syndromes. If we calculate from this, if you have the involvement of the 6th, 7th and the corticospinal, that is the Millard-Gubler syndrome. If you have the involvement of the medial longitudinal fascicle, 6th, 7th, medial lemniscus and corticospinal also, again on the medial aspect, that is number 6, the Fovley syndrome. While if you have the involvement of the spinal lemniscus and the middle cerebellar peduncle, yes, that is what? The Mary Fox or the lateral pontine syndrome. और repetition of the orientation क्या इसमें बताएं? 3 boxes, midbrain, pons and medulla, the lateral aspect and then the medial aspect. We have a syndrome number 1, that is Weber's, in which the medial midbrain areas are involved, the third nerve and the corticospinal. We have again on the medial aspect the red nucleus and the third nerve together. That is a claudase number 2. And then, you are asking me 1, 2, and 3. Oh my god, Vinod. This is the co-orientation of 1, 2, and 3. Keep your mind open. 1 plus 2 is 3. That is Benedict. 1 plus 2 is 3. That's Benedict. Okay. 3 cranial nerve and the superior cerebral peduncle is number 4, North Nagel. Okay. Number 5 is Miller Gubler. Number 6 is Fovlis. Number 7 is Mary Fox. And then we have with us what? The medullary syndrome. That's very simple. The 12th cranial nerve, medial lemniscus, and the corticospinal all together. The French word, the Gerine syndrome, number 8. We have the sensory of the 5th part, 7th, although they include, but it's not very correct. 8th should write, 8th actually. Should be written as 8. Just make a correction over here, make it as 8. 8. 9, 10, spinal lemniscus, sympathetic trunk, and the inferior cerebellar peduncle, 9. Okay. So that's a lateral medullary syndrome known as the Wallenberg syndrome. Okay. Now the problem which lies in the books is that Benedict and Claude are often interchanged. I've highlighted it so many times. This is the correct version on the higher textbook. So we have Wallenberg number 9, the lateral medullary syndrome that we have over here. Okay. Number 8, the Gerine syndrome. Okay. So some students are writing that we have just enrolled for DVT. Don't embarrass us, but telling that you have taught this and that. See, I'm not telling in a sarcastic way. I'm telling you in a realistic way. This is a revision program. Let me remind you again. This is not the first reading program. You have to be very clear in your basics first before approaching all these things. Okay. So a lot of hard work is still required at your end, and still we are far ahead from the actual NEET PG if we take it in March. So you can utilize that time to know what to read and what to leave by looking at the DVT notes at least. Okay. Yes, the medial medullary syndrome happens due to the involvement of the ASA, the anterior spinal artery. The lateral medullary syndrome more often due to the involvement of the vertebral than the pica. Okay. The pontine syndromes generally happen due to the involvement of the basilar artery, BM writing, and always the midbrain syndromes will happen due to the involvement of the posterior cerebral artery or the PCA. So this has been asked so many times recently. Wallenberg lateral medullary is due to involvement more often due to vertebral than the pica. The medial medullary is anterior spinal artery, the Gerine syndrome. Okay. Right. Chalo, let's get wiser on these topics by solving MCQs. 43-year-old female was applying her makeup one morning and she noticed her right eyelid appeared to be different and pupil appeared to be larger than the left one. The large pupil, dilated pupil, may be seen in. Tell me. Tell me. Horner's, pontine lesion, morphine, or a lesion in the midbrain? Very simple, straightforward question. I'm asking you, mydriasis, that is dilated pupil, is seen in third nerve palsy that connects with which part of the brainstem? Midbrain. So look at morphine, poisoning, Horner's syndrome, and pontine lesion. They always have got a pinpoint pupil. A pinpoint pupil. So what is so difficult in answering these questions? And don't get paranoid if you have seen something new for this for the first time, arrangement of all the syndromes. It's just a quick recap. Okay. 66-year-old man has sudden painless onset paresis of his right upper and the lower face. Inability to abduct the right eye. lateral rectus palsy, facial nerve palsy, that is of the type element, and paresis of the left arm and the leg. Can you explain me this? Can you explain me this phenomena first of all? My face is weak on this side, my body is weak on the other side. That is hemiparesis, known as what? Yes, the crossed hemiparesis. Very good. And what is this? Something we have discussed initially, the Millard-Gubler syndrome. Millard-Gubler syndrome? Yes. On which side? Now my question is on which side? So if it is a right sixth nerve, right seventh nerve, it has to be on the right side. Left side weak means corticospinal on the right side. Don't have any right to left confusion and dyslexia on this. I'll repeat this again. This is a typical Millard-Gubler, a ventral or anterior pontine syndrome on the medial aspect, in which on the right side, seventh nerve element is gone, complete face is weak. Right side sixth nerve palsy is seen, and the left side the body is weak because on the right side the corticospinal tract is affected. So sixth, seventh, corticospinal, everything gone on the right side. Oh, sorry. Yes. Please don't carry any dyslexia and right to left confusion. Otherwise, in exam, that is a meeper. No sarcasm, only reality. Okay. Right. Now answer this question now. Next one. Lesion in the lateral medulla on one side may give rise to what? Contralateral weakness of tongue, contralateral weakness of palate, ipsilateral facial weakness, or Horner syndrome. Lateral medulla carries the sympathetic trunk with it. Lateral medulla carries the sympathetic trunk with it. That's the biggest hint. Sympathetic trunk on the lateral medulla is affected, will have ptosis, meiosis, Horner syndrome. Correct? No doubt on this. It's a very simple question. Now, can you guide me where will be the tongue weakness be seen? Will the tongue weakness happen there or not? No. Palate weakness will happen 9th and 10th nerve palsy, but on the same side. Because cranial nerves do not cross the midline. The corticospinal only crosses the midline. Okay. So that's a very simple question, straightforward question. Okay, good. Then we have our friend again, multiple sclerosis, in which the motor weakness could be a symptom in them with an OTOF phenomenon. OTOF phenomena, if you remember, is a kind of a visual blurring they have got. They got a visual blurring on exposure to heat. And this is nothing but the exacerbation of the symptoms of optic neuritis that they generally face. They got a Lhermitte sign also with them, in which they've got paresthesia, which will be seen in them on flexion of the neck. On flexion of the neck. They've also got facial pain, that's trigeminal neuralgia, that could be seen in them. Internuclear ophthalmoplegia, I know. I hope you know. My this eyeball goes on to the right, and the left eyeball doesn't move, and this eyeball, which is abducting, has got an nystagmus. Can you tell me the reason between I and O? Internuclear ophthalmoplegia, what is the reason behind this? It is due to lesion at the MLF. Usually in these patients, you've got exacerbation and remission in this format that we know as relapsing multiple sclerosis. That is seen in approximately 90% of the cases. And progressive type could also be seen in them, in which the thing keeps on increasing. That is known as primary progressive MS. That is seen in approximately 10% of the patients. Sensory symptoms, yes, which got often exacerbated on flexion of the neck, paresthesia. Cerebellar signs could be seen in them. Language, yes, the talking in them is often slurred. The speech is often slurred in them. Now, evoke potentials are also important, that we know as visual evoke potential. The visual evoke potential means to diagnose what? Optic neuritis. Rule out if what? If the optic neuritis in the patient is bilateral. There is a condition in which you will have a bilateral optic neuritis, who is a younger brother of multiple sclerosis. I'll talk about that also. In these patients, we got oligoclonal bands in the CSF. Steroids are generally given in the acute attack in the acute exacerbation. Symptomatic therapy is given and immunotherapy has to be given. Let's try to answer this question. It's a very smart question. Which of the following is the most effective drug for disease modification as per the EDSS scoring system? Tell me. Indirectly, we are asking you what is a drug which is going to decrease the disability in the patient, not the relapse, the disability in the patient. See, I'll tell you this. If you look at the disease modifying drugs, there's one drug which we often give to decrease the number of relapses. There's a one drug which is considered to be best to decrease the disability. So the best disease modifying agent to decrease the number of relapses is natalizumab. Disability that you quantify by the EDSS scoring scale is mitoxantrone. So the best drug that we consider to decrease the number of relapses in MS is natalizumab. The drug which is best to decrease the number of disability, the amount of disability that you quantify as per the EDSS scale, is the mitoxantrone. So it's a very clever question. Read the question again. He's not asking you a direct question, he's asking you indirect question. What is the best disease modifying agent to decrease the score as per the EDSS scoring scale? So in the EDSS scoring scale, we look at the disability, not the number of relapses. So the drug that is best to decrease the amount of disability is mitoxantrone. One to decrease the number of relapses is natalizumab. That's why it's a very, very clever question. Okay. So don't, not interferon beta. It's not the best. It is the preferred agent. He's not asking you the preferred agent to start with. He's asking you direct question, the best or the most effective therapy. Okay. Fingolimod, yes, I agree, is a good drug, but it's an oral therapy. If they ask you oral medication, it's fingolimod. So that was a kind of a googly question that we got, right? Then we have neuromyelitis optica, metron, namo. Okay, so they got neurological symptoms in form of brainstem symptoms, cerebral symptoms, good question. Why not best? Why interferon is not the best but still drug of choice? See, drug of choice is basically given as a drug which is going to be the most not the most effective, but carrying a lesser side effect with it. So if you look at the safety profile, interferon beta fares very good over there. It's one of the drug which doesn't have too much of serious side effects. But natalizumab, if you start, yes, you're going to have a problem known as PMLE. Okay, area prosterma symptom could be seen in form of vomiting and hiccups. Myelitis could be seen in them as transverse myelitis, in which the patient would have 3 or more than 3 segment involvement. Optic neuritis that could be seen in them is generally seen to be bilateral. Now, which of the following is false or incorrect about NMO? Onset occurs in childhood, transverse myelitis is seen, interferon beta is ineffective, or oligoclonal bands are commonly seen in Devick's disease or NMO? Tell me, what is incorrect? Yes, oligoclonal bands are commonly seen in MS, not in NMO patients. That's an incorrect answer. Okay. Now we have a patient of suspected meningitis. Someone has told me to be fast. I'll be fast, don't worry. So a lot of things are just now written over here. We have a patient with us with fever, neck rigidity, and headache. That's a try to define meningitis clinically. Ideally, you start with sorry, empirical therapy depending on the age of the patient. If the patient is adolescent, you give them a ceftriaxone. If he is an adult, give them a ceftriaxone with vancomycin. If it is an elderly patient, give them ceftriaxone vanco with the ampicillin. And then always look out for the red flag sign which are fails. If the patient is having a focal neurological deficit, altered mental status, if the patient is immunocompromised, lesion in the brain is possibly found on the clinical examination, or the patient has got seizure, then in that case obtain a neuroimaging and rule out what? A space occupying lesion. No, then proceed for what? Lumbar puncture. CSF analysis. No, I'm nothing writing over here, it's more of reading now. CSF analysis, you look at the CSF glucose. If it is below 40, you got hypoglycemia, you look at the cell type. If the cell type is predominantly neutrophilic, you think about bacterial meningitis. You subject the CSF sample for latex agglutination, culture and staining of course. And for Neisseria meningitis or meningococcal infection, you can start with ceftriaxone. For the pneumococcal, ceftriaxone and vanco. Listeria, ampicillin is required. Just a quick recap on the duration of therapy. Ceftriaxone 7 days for meningococcal. Ceftriaxone and vanco for pneumococcal for 2 weeks or 14 days. Listeria ampicillin for 3 weeks or 21 days. Tubercular meningitis, lymphocyte predominant picture is seen, TBM. You have to subject the patient CSF for culture, PCR and AD additionally. And for CNS TB, please remember, CNS TB you have to give the patient ATT. ATT is given to the patient for a duration of 12 to 18 months ideally. Steroids are given to the patient for 2 months time. If the CSF picture doesn't show you a low CSF glucose, but it shows you a lymphocytic picture, then think about the viral herpes simplex virus. Do an MRI to look out for the temporal hyperintensities. And maybe you also have to do a PCR, which is the most sensitive test to diagnose this disorder. And acyclovir has to be given through the IV route 21 days. 21 days time. Okay. Why steroids? Steroids are given in them generally to decrease the chances of endarteritis, which is very high in TBM, to decrease the chances of what? Infarct in the patient brain. Okay. 63-year-old female was brought by her daughter complaining of new onset persistent headache for the last 2 weeks that would awake her from sleep. That means something related to what? Raised ICT. She felt persistently nauseated, drowsy throughout the day. Her CT scan shows hydrocephalus, raised ICT again. Which of the following is a most likely explanation for a hydrocephalus? Tell me. Subdural hemorrhage is totally ruled out because CT scan doesn't show you an SDS there. Idiopathic intracranial hypertension can come with a raised ICT, but generally the age affected over there is young obese females. Here, the ventricle size often remains to be normal in idiopathic intracranial hypertension. Herpes simplex will always come with temporal hyperintensities typically. Okay, and what are we left with? Tubercular meningitis. So sometimes I always tell you while solving the MCQ, you don't know the correct answer, don't worry. If you know the options, you can possibly arrive at the correct answer. Because in patients of TBM, generally we find basal exudates that will impair the flow of CSF going up and down, resulting in a hydrocephalus in the patient. Now going into the headache. a simple table that will just give you a quick recap of the headache topic. I've got a patient with headache, which is on one side, unilateral with scalp tenderness. It's an elderly female who comes to me with a unilateral headache. Maybe she's telling me it's stabbing a head with scalp tenderness. What is that? Temporal hyperintense, temporal arteritis. The giant cell arteritis. Very good, GCA. If the patient is having unilateral headache with nausea, we think about migraine. Now tell me, my patient has got headache which is throbbing but without nausea. It can be temporal, it can be occipital, throbbing headache without nausea. And one fine day, the patient has got an explosive headache out of that and with neck rigidity and becoming unconscious. What is that? Aneurysms are pulsatile in nature. They don't have nausea as a classical symptom with them. Not cluster. Now we have a headache which is seen to be bilateral. On both the side it can be seen. And it is dull aching with papilledema. Raised ICT, papilledema, dull aching, bilateral headache. Pseudotumor cerebri. Think about pseudotumor cerebri. Raised ICT. Intracranial hypertension. Benign. Now your patient has got a dull aching headache without papilledema. It can be a band-like sensation on the head region. The tension headache that we have got. Or the tension type headache that we see. Sometimes the headache is not dull aching, but it is more explosive and retroorbital. And just add over here, it's a unilateral retroorbital explosive headache in a male patient with lacrimation after drinking alcohol. Yes, this is something that we were all talking about, the cluster headache. Right? Simple? No confusion, I believe. Now let's quickly go to the treatment of choice. Tension headache, if it is episodic, you give to your patient NSAIDs. If it is chronic, you give them a tricyclic antidepressant like amitriptyline. Acute attack, migraine, you give triptans preferably. Prophylaxis, you can give to your patient beta blocker, tricyclic antidepressant, servoselective calcium channel blocker, or an anti-epileptic like valproate or topiramate. Cluster headache, don't forget, acute attack, you give oxygen inhalation at a high flow of 10 to 12 liters per minute for a short duration. And for prophylaxis, in a cluster headache patient, the ideal therapy is always verapamil. Right? Right. Which of the following does not require urgent neuroimaging? A easy question. A headache in a 30-year-old mother of a 1-month-old infant, a newborn kid, mother postpartum. The coagulability of the blood will be still high like a pregnancy. So you can think about one thing over there as cerebral venous thrombosis. That could be a reason for a headache in this patient. 20-year-old male with a sudden onset severe headache with neck rigidity. Think about subarachnoid hemorrhage. New onset progressive headache in a 60-year-old elderly female. Think about a space occupying lesion or a brain tumor. Headache in a 15-year-old young female. Don't think too much. It can be a simple refractive error or convergence problem. Okay. Right, last slide, previous slide, all of this you'll get in the PDF, don't worry. So that was a quick recap about headache. Now going to the neurodegenerative disorder quickly. Alzheimer disease, the patient has got an anterograde amnesia to start with, later on ending with a retrograde amnesia also. That's why I'm putting an anterograde first over here. As the life expectancy increases in anyone, the risk of Alzheimer will always increase. People who are more elderly, above the age of 70, are more prone to have Alzheimer disease. There is a zapped loss of acetylcholine neurons in a structure known as nucleus basilis of myrinate. Nucleus basilis of myrinate. Also in these patients, the problem can be hereditary, coming through certain mutations which can be chromosome 21, 14, 1 and 19. 1 and 19. And the hereditary problem in Alzheimer is often due to autosomal dominant chain. Most of these patients will have the entire hippocampus being lost, which can be seen radiologically also. They can be identified with the neurofibrillary tangles which are seen in the brain intracellularly, and enterorenal degeneration could also be seen in them. So that's a quick recap of Alzheimer's disease. Nothing new in this, you already know all these things. Similarly, the younger brother of Alzheimer, that's a frontal lobe temporal dementia. The frontal lobe symptoms are seen in them in form of behavioral abnormalities. These patients will have behavioral abnormalities quite early into the picture, while dementia could be seen in them generally late. Tau proteins are the culprit proteins seen in Alzheimer and FTD both, causing neurodegeneration in both the sets of patients. Now we have an elderly man or a grandpa who is wet, wobbly and wacky, identified by his favorite doctor Hakim, not Hakim but Hakim's, the legendary Hakim's triad, a triad simple to remember, the good triad. The person is wobbly, in a sense they've got gait ataxia, they've got urinary incontinence, they've got memory loss or dementia. The great triad which our grandpa often visits earlier, Hakim or the not Hakim but Hakim's triad, in a patient of NPH. Simple. Let's answer this question. A 60-year-old alcoholic male presents with urinary incontinence, abnormal gait and loss of memory. So urinary incontinence, abnormal gait and dementia. The good triad back, what is that? It's a case of NPH. The only problem that you will face while solving this question, whenever you read the word alcoholic, you think he has gone to Goa. No, that's not the Goa triad. Where does the Goa triad fall into? The Wernicke's encephalopathy, in which the patient is having disorientation or confusion which is global for time, place and person. They've got ophthalmoplegia with the lateral rectus palsy. They've got ataxia, and the basic problem in them is obviously a thiamine deficiency. Okay. The Korsakoff is the elder brother who's got retro and antero both. But the most common type of amnesia that we find in them is anterograde amnesia. They often have got a habit to hide it from the people around by confabulation. That's a patient of Korsakoff. Okay. Then CGD again is a patient who is mad, bad and ultimately very, very sad. Myoclonus that we find in them is on touch or a stimulus known as startle myoclonus. That is always seen to be the most common presentation in them. They also got ataxia with them and dementia later on. They often happen in bits and pieces that basically reflects the word sporadic. So the most common type of Creutzfeldt-Jakob disease is sporadic CGD in bits and pieces, that means sporadic. The general age of onset that we find in them is somewhere seen to be at 66 years average. I'm taking the average, it can go from 50 to 75 also. In the sporadic CGD, as we know, the death happens quite early, within 4 months of onset. The spikes are seen on the EEG, which can be in a phase 3 triphasic. These patients have also got altered signals that could be seen in their thalamic region. And they've got degeneration that is known as The brain becoming a sponge, the spongiform degeneration. Okay, so that's a patient of CGD who is mad, bad, and sad, all three together. Let's see this patient. 50-year-old woman has come to you with double vision and diplopia. She is suffering with depression, unsteadiness of gait, sad depression, unsteadiness of gait, ataxia. Her whole body appears to jump in presence of loud sound, that is a startled myoclonus that she is coming with. The MRI shows a basal ganglia hyperintensity. One zone which is included into the basal ganglia functionally is thalamus, so they've got thalamic hyperintensity. That is a patient of CGD or the Kurzweil-Jakob disease. Similarly, a small topic again, Huntington's chorea, which is an autosomal dominant disorder. Okay, these patients come to you with dementia late into the picture. They come with chorea quite early in the picture with certain behavioral abnormalities. And in them we find atrophy. Where? We find it in the caudate nucleus, right? So caudate nucleus is a zone which is seen to be atrophied in them. Bits and pieces means sporadic in a sense. So something which is ectopic in bits and pieces is also known as sporadic. So one type of CGD is most common, that is sporadic CGD. And in them, we find the basic defect lies in a trinucleotide sequence of CAG, which is found to be elongated in them. So number of CAG repeats that generally we find in them is more than 40 repeats. So I'm only highlighting you the important points over here. Okay. 50-year-old, I'll give you lunch as soon as we complete. Okay. I'll not give you lunch, I'll give you lunch break. I know I was supposed to take till 2, but it got prolonged because of our dance and some intermittent breaks, the server breaks and all. I know. दिखाई दे रहा है, अंधा नहीं हूँ. कहते हैं ना सुनाई दे रहा है, बहरा नहीं हूँ, महरा हूँ मैं. Don't worry. Okay. 50-year-old man presents with movement disorder along with developmental, emotional and cognitive problems. Which of the following is a likely diagnosis that you can make over here? Nothing but Huntington's chorea, very simple topic. Okay. Now a quick recap of GBS, Guillain-Barré syndrome, the Brighton criteria that we have to diagnose it. The patient has got bilateral flaccid weakness in the limbs. If you remember, the pattern is always seen to be ascending. Decrease or absent DTR in the weak limbs that we know in a format of areflexia in the patient. Monophasic pattern, which is an onset to the maximum weakness that would be achieved in them within 12 hours to 28 days. That accounts to 4 weeks. Electrophysiological findings consistent with GBS in which you have got loss of F wave. There is a cytoalbumino dissociation in which in the patient the albumin is increasing and there is no pleocytosis that you will find. And always rule out something which can mimic a Guillain-Barré syndrome, which can be what? If it is a descending paralysis, think about BPD. So there are 3 differentials that we keep in mind while evaluating a patient of GBS. B stands for botulism poisoning, P stands for polio, and D stands for diphtheria. The young man had suddenly developed paraplegia following a short febrile illness, lower limb weakness after some infection, post-infectious. Examination reveals a lower motor neuron paralysis, that means flaccid areflexic, with no sensory and no bladder and bowel involvement. The CSF examination is likely to reflect what? GBS, what is it going to likely reflect? The albuminocytological dissociation, high albumin and no pleocytosis. Simple thing, right? Okay, a quick recap on the gait. The person walking is with small paces. Yes. His posture is upright, slightly extended, and the arm swing is normal. That means his arm swing is normal like this, but he's not taking his leg too far off. is marching ahead like a soldier in a parade that is seen in a frontal lesion that we know as marche a petit pas. Sometimes the patient of Parkinson stoop posture with no arm swing and small paces means shorter steps. That is a patient of fascinating gait. Fascinating gait. Parkinson disease. Now we have a patient in which the paces are not small, they are normal paces. But the feet separation shows a crossover. So maybe not reflected in the camera properly. But if you see the patient walking, he'll cross his legs like this, like the scissors are moving. This is what is known as a scissoring gait. The scissoring gait. There's another patient with us whose feet separation is wide based. Okay, whose feet separation is wide based slightly, and he's taking a step high above the ground while walking. Maybe he's keeping his feet wide apart. Okay, and he's keeping it like this on the floor to feel the floor better. And he's taking a step high above the ground as if he's stamping it on the floor. Tell me, what kind of gait do you think about? The feet separation is wider. The person takes his feet high above the ground and puts it on the ground forcefully like this, like an elephant walking, with a wide feet separation. That's very important thing. Stamping gait seen in a posterior column lesion. Good. But now this patient is having a wide base stance or a gait while walking with no high steppage. That means he is walking like this, keeping his feet wide apart, swaying on both the sides. That's a truncal or the cerebellar ataxia. Cerebellar or the drunken gait. Now I'll differ this stamping, what you have in mind, from a foot drop. Let's try to differ this. Your patient has got a normal feet separation with a high steppage. So there is no wide feet separation. There is a normal feet separation with a high steppage. He's tipping his foot high above the ground every time while walking. Yes. That you think about what? A foot drop. High steppage with a normal foot separation. Foot drop, high steppage gait, also known as a equine gait. Now this time the patient feet is kind of normal separated with no high steppage, but the pelvis every time is rotating. It goes like this. Yes, what is this? He's waddling. He's a waddling gait patient. Myopathy patient, waddling gait. Okay. Brown-Séquard syndrome, a quick recap. In the patient at the level of the lesion, the posterior column, spinothalamic is affected on the same side, ipsilateral. Below the level of lesion, the spinothalamic is affected on the opposite side, contralateral. Below the level of lesion, the posterior column is affected on the same side, ipsilateral. How to remember it? BOSS, BSS, Brown-Séquard syndrome. BOSS, a BOSS topic in which at the level of the lesion we will have loss of vibration and proprioception on the same side, I, ipsilateral. I stands for ipsilateral. Weakness will be again ipsilateral at the level of the lesion, which is of the type L. So ipsilateral element weakness. But below the level of lesion, the temperature and pain or the spinothalamic is affected on the OP side, the opposite side. The UMN weakness will again be seen ipsilateral below the level of lesion. And vibration and proprioception is again on the same side, ipsilateral. So BOSS, the Brown-Séquard, is a VIP who will sit at the level below to stop the unwilling VIP to enter. Okay. So maybe a mnemonic which I tried to figure out. Even if you remember, stop is final. Stop is okay. Temperature, spinothalamic is involved on the opposite side. Rest everything is ipsilateral. Okay. Which of the following components about Brown-Séquard syndrome is true except? There is an ipsilateral extensor plantar response, UMN. There is an ipsilateral pyramidal tract involvement, UMN. There is a contralateral posterior column tract involvement, yes, below the level of lesion. There is a contralateral posterior column involvement, no. It is always ipsilateral at the level as well as below the level. Okay, so I'll repeat it. BSS, Brown-Séquard syndrome, in which the patient's vibration and proprioception, that is posterior column, is affected on the same side ipsilateral. There is weakness which is seen at the level of the lesion, which is LMN, on the same side ipsilateral. Spinothalamic, ST, is again involved on the same side ipsilateral. Below the level of lesion, spinothalamic is involved on the opposite side. Human weakness will be seen on the same side, and vibration and proprioception posterior column again ipsilateral. Okay. Syringomyelia. मोए I know. जो याद था वो भी भूल गया सर. Okay. Syringomyelia is a patient in which there is a cape-like sensory loss. More than 50% of them have got a Chiari malformation in them, which is seen in a type 1. They're very weak at the level of the lesion due to LMN because of the involvement of the anterior horn cell. In them, we always have an intact posterior column and temperature is lost. The onset in them is generally found to be young, in a bracket that we consider between 20 to 40 years. Oh, sorry, 10 to 30 years, very young. Okay, so this is a cape-like distribution that will be seen in the patient. Okay. Which of the following clinical presentation will not occur in a lesion of the spinal cord? Tell me. Bladder involvement will occur, sensory level at the specific level will occur, LMN, UMN on both the lesions will occur. Cross hemiplegia, no, that will always occur in a pontine lesion, not here. In enlargement of the central canal of the spinal cord, which gustable muscle fiber is affected first? If you look at the central canal, that's quite in the center, in which the fibers are arranged like this, CTLS. And if the central canal enlarges, the fibers which are on the above part, cervical, will be involved first, and then it goes down. So obviously the shoulder upper fibers would be involved first in them. So central canal intramedullary lesion will always come to you with a descending paralysis. Okay. AHC, anterior horn cell. Okay. Someone is asking, class started? Are class ending? Conus cauda, 2 people. Conus is a cone-shaped enlargement of the spinal cord that you see at the distal part. In a conus medullaris syndrome, generally, we have got a normal knee jerk and a U-shaped sensory loss could be seen in a shape known as saddle. So if you look at the back or the butt region of the patient, they would have a sensory loss in this pattern known as saddle. As they were sitting on a horse for a very long time and you get down from the horse, you'll feel that you are sitting on the horse because the sacral dermatomes are basically supplying the perineal region around like this. And they also present with the overflow incontinence. Cauda. Cauda is a problem in which the nerve roots are basically damaged. They will come with an urge incontinence. Since the nerve root on one side is damaged more than the other side, the problem will be asymmetrical and limb reflexes are generally absent, which is not only knee but ankle also. Now, which of the following is a feature of conus medullaris syndrome? Tell me. An absent knee jerk? Yes. Gradual and unilateral onset? No. Sorry. Absent knee jerk? No. Knee jerk is normal. Overflow incontinence is seen in them. Gradual and unilateral onset, asymmetrical areflexic paralysis. Tell me. In patients of conus, we always find an overflow incontinence, not an urge incontinence that regularly. An asymmetrical areflexic goes with cauda equina more often. Knee jerk is normal in these patients. So cone-shaped enlargement of the spinal cord at the distal end that contains the sacral segments is involved in conus medullaris, while the nerve roots coming out from there like this and this of the L1, L5 and S1, S5 is the chord equina part, right? Now the showstoppers, Friedreich ataxia, very important topic. It's a familial disorder which is autosomal recessive in trait, in which the GAA sequence is repeating in them more than 200 times. In these patients, we have got impaired posterior column, extensor plantar, and an absent DTR. In these patients, we often have got insufficient vitamin E deficiency with a foot deformity that you can see in this image as pes cavus. And what is this? A kyphoscoliosis that could be seen in them. In these patients, one of the most common extraneuronal symptom that could be seen in them is hypertrophic cardiomyopathy. Okay, so that's about the Friedreich ataxia that we have. So I'm telling you only the important points. Tabes dorsalis, the tracts involved in them are the posterior column only. The Argel-Robertson pupil, in which the compensation reflex is present and the light reflex is absent, is seen in them. The bladder is involved in these patients. They got excessive pain, and due to posterior column involvement, they've got a typical stamping gait while walking. And if I hold them with the feet and leg together, they will sway with eyes closed. That reflects a posterior column lesion known as a Romberg test. Okay. Subacute combined degeneration. These patients have got spasticity due to involvement of the corticospinal tract. These patients have got ataxia due to posterior column involvement. They've got cognitive problems and they do come with vitamin B12 deficiency. That could be reflected in form of pain in the extremity neuropathy, and even glossitis could be seen in them. That's SACD. Spasticity, ataxia, cognitive problems, and vitamin B12 deficiency. SACD. Now the last ball of the match. Amyotrophic lateral sclerosis is again inherited, which is more often in a way considered to be sporadic than familial. And the most common gene that could be leading on to ALS is C9 ORF72 gene. On chromosome number 9. In these patients, we have atrophy in the corticospinal tract. Please do remember them. The eye muscles and the bladder muscles are bladder is perfectly spared in them. They got a mixture of UM and LM sign. Cognition is normal. Talking and eating is impaired. Talking is impaired, known as dysarthria. Eating is impaired, known as dysphagia. That reflects basically in them what? The bulbar problem. And treatment is often supportive. But apart from this, is one drug approved for treating patients of ALS every time, known as riluzole. Okay. Then we have the expensive disease, the spinal muscular atrophy, in which the patient got spinal lesions located at the anterior horn cell, creating an element type of weakness in them. And the ideal drug for treating them nowadays is considered to be nusinersen. And the problem lies on the SMN gene in these patients. Okay. Any doubts, any queries, genuine ones, please do let me know. So this has been a session which has been a quick recap session. People who have attended it for the first time might find it difficult. What is this going on? I'll tell you, there's still time with you. Read this DVT notes so that you have an understanding of what to read and what to leave. I've specifically gone into things and topics which are uh, important for the exam purpose and highlighted you through some abbreviations and mnemonics. So no moe moe on this. Okay.